If you are watching this, there is a reasonable chance you already walk regularly. Maybe every morning before breakfast, maybe 30 minutes after dinner, maybe not as far as you used to, but consistently, faithfully, because you understand that staying active is one of the most important things you can do for your health at this stage of life. That consistency matters. It is something to be genuinely proud of. Most people your age are not doing it, but here is what no one has told you, and what this video is going to change. Walking regularly and walking correctly are not the same thing, and in adults over 60, the gap between those two things carries consequences that are measurable, progressive, and quietly serious for your joints, your cardiovascular system, your balance, and ultimately your independence. The 5 mistakes covered in this video are not obvious errors. They are not things you would notice in yourself without being told. They are so normalized, so common, and so far outside what most people consider wrong that the majority of seniors making them will continue doing so for years, sometimes for decades, without a single correction from a doctor, a therapist, or anyone else. Consider this. Falls are the leading cause of injury-related death in adults over 65 in the United States, and a significant proportion of those falls trace directly back to correctable gait mechanics, not to age, not to bad luck, not to anything irreversible. This video will walk you through all 5 mistakes, each one explained with anatomical precision, each one paired with a correction you can apply immediately. Stay through mistakes 4 and 5. Those are the 2 that almost no one talks about. There is a belief embedded deeply in our culture and in most medical advice given to adults over 60 that goes something like this: any walking is good walking. Just keep moving. That belief is not entirely wrong, but for millions of seniors, it is incomplete in a way that is causing real cumulative damage. Here is the contrast that this entire video is built around. What most seniors believe: I walk every day. My joints are being maintained. My cardiovascular system is being supported. I am taking care of my body. What is actually happening in many cases? The same mechanical errors are executing with every single step, compressing the same joint surfaces in the same abnormal pattern, shortening the same muscle groups further with every mile, and embedding the same postural imbalances more deeply into the nervous system each time they repeat. Repetition does not fix errors, it reinforces them. And here is the part that should concern you. Gait education is almost never provided in a standard medical setting. Most adults over 60 have never had anyone, not a primary care physician, not a specialist, not a personal trainer, actually watch them walk and say, that needs to be corrected. Walking is a biomechanical system. Every system degrades predictably when operated with consistent mechanical error. These 5 mistakes follow a precise pattern, and patterns can be corrected. To understand why these 5 mistakes matter so much more at 70 than they did at 45, you need a clear picture of what is changing inside your body's movement system. Because these are not abstract concepts. They are specific, measurable biological shifts that transform minor mechanical errors into meaningful sources of damage. The first is sarcopenia. Beginning around age 30 and accelerating significantly after 60, the body progressively loses skeletal muscle mass and contractile strength at a rate of 3 to 8% per decade. The muscles hit hardest are precisely the ones walking depends on most: the gluteal complex, the quadriceps, and the hip flexors. These are the primary engines of propulsion, stabilization, and postural control during every step you take. As they weaken, the body compensates, and those compensations are where the 5 mistakes begin. The second is proprioceptive decline. Embedded in the joints and soft tissue of your feet, ankles, and knees are sensory receptors that continuously report position, pressure, and surface information to the brain. With age, the sensitivity of these receptors measurably deteriorates. Your brain is receiving a slower, less accurate picture of where your body is in space, and making balance corrections based on incomplete data. This is one of the most underappreciated contributors to fall risk in older adults and one of the most correctable. The third is articular cartilage thinning. The protective cartilage lining your knee, hip, and ankle joints gradually thins with age. Abnormal mechanical loading, the kind produced by every mistake on this list, now causes direct articular damage that the same errors simply would not have caused 20 years ago. The fourth is reduced spinal mobility. The intervertebral discs stiffen, the paraspinal muscles shorten, the thoracic spine rounds forward. This cascade alters posture at the foundation, and that altered posture ripples through every phase of the gait cycle, from head position to heel strike. Here is what connects all four. Each of the 5 mistakes ahead either directly accelerates these processes, is directly caused by them, or both. And every correction interrupts that cycle at a precise biological point. These are not careless mistakes. They are not the result of laziness or inattention. They are the predictable mechanical consequences of an aging body that has never been given specific corrective instruction. And they are happening right now on the walks of millions of adults who believe they are doing everything right. Here is each one, precisely and in full. Mistake 1. Looking down at the ground while walking. This is the most universal walking mistake among adults over 60, and it begins with what seems like a completely reasonable instinct, watching where you are going. The problem is not the intention, the problem is the mechanics. When your gaze drops to the ground directly in front of your feet, your head follows. The head, which weighs approximately 10 to 12 pounds in a neutral position, shifts forward of the spine. For every inch of forward head displacement, the effective load on the cervical spine increases by roughly 10 pounds. At full downward gaze, that load can approach 40 to 60 pounds of compressive force on a spine that was designed to carry 12. That forward head position shifts your entire center of gravity anteriorly, in front of your base of support. Your body is now perpetually tipping forward, requiring constant muscular correction to prevent a fall. In adults with existing thoracic kyphosis, the forward rounding of the upper back that progressively increases with age, looking downward does not just add to an existing postural problem. It accelerates it, tightening the reinforcing loop. Poor posture leads to altered gait, leads to increased fall risk, leads to fear of falling, leads to reduced activity, leads to further postural and muscular deterioration. The correction: train your gaze to rest 10 to 15 feet ahead at eye level during all walking. Use a landmark anchor, a parked car, a gate, the end of the block. Fix your eyes there, not at the pavement beneath you. This single adjustment immediately repositions the cervical spine toward neutral, redistributes your center of gravity back over your base of support, and activates the deep postural stabilizers of the upper back that have been switched off by years of forward head carriage. Mistake 2. Shuffling the feet instead of lifting them fully. If mistake 1 is the most common, mistake 2 is the most dangerous. Shuffling, the failure to achieve full foot clearance during the swing phase of each step, is the single most direct mechanical precursor to trips and falls in older adults. It does not require a significant obstacle, a hairline crack in the pavement, a slightly raised threshold, the edge of a rug. Any of these becomes a fall risk the moment the foot fails to fully clear the ground. But shuffling is not simply a habit. It is a clinical signal. It indicates weakness in the hip flexors, the muscles responsible for lifting the thigh and initiating the swing phase, and reduced neural activation of the anterior tibialis, the muscle along the outer shin responsible for dorsiflexion, the upward lifting of the front foot with each step. When the anterior tibialis is underactivated, the foot drops rather than lifts, and the shuffle becomes the default pattern. In adults with early neurological changes, a persistent shuffling gait is also associated with Parkinson's disease progression and white matter changes affecting motor control pathways. This is a symptom that warrants documentation in the medical record, not simply a mechanical correction. The circulatory consequence is equally significant. Shuffling eliminates the heel strike to toe off rolling sequence, reducing calf muscle activation during push-off, directly impairing the calf muscle pump that drives venous blood return from the lower legs to the heart. The result is venous pooling, lower leg swelling, and the heavy leg sensation that many adults accept as inevitable. The correction: deliberate dorsiflexion awareness. Consciously think, lift, and place with every step, rather than push and slide. Daily ankle dorsiflexion strengthening, seated heel raises, toe taps, resistance band pulls, accelerates the neuromuscular repatterning required to make this correction automatic. Mistake 3. Leaning forward at the trunk during walking. This is the mistake that feels the most invisible, because for most people making it, it feels like nothing at all. Anterior trunk lean, even a subtle forward inclination of the torso during walking, shifts the body's center of mass in front of the base of support. The immediate biomechanical consequence is the deactivation of the gluteal muscles. The glutes are the primary propulsive engines of correct walking mechanics, and when the trunk leans forward, they are placed at a mechanical disadvantage that progressively removes them from the movement. Propulsive load transfers instead to the lumbar spine and the knees, two structures that are not designed to absorb that demand over thousands of daily repetitions. Lower back pain during and after walks is frequently the first signal. Accelerated knee joint stress follows. This error is predominantly caused by three compounding factors in older adults: prolonged daily sitting, which chronically shortens the hip flexors and anteriorly tilts the pelvis; progressive thoracic kyphosis; and the sarcopenic weakening of the glutes themselves, which removes the muscular feedback that normally holds the trunk upright. The insidious quality of this mistake is that it feels normal. The body adapts fully to the position. There is no sensation of leaning, which is precisely why it is never self-corrected. The correction: the tall spine alignment cue, ears over shoulders, shoulders over hips, hips over ankles. Before every walk, stand at your starting point, take one full diaphragmatic breath, lift the sternum, gently draw the shoulder blades back and down, and establish that vertical stack consciously. Hold it for the first 2 minutes of every walk. Over 4 to 6 weeks, proprioceptive recalibration begins, and the upright position starts to feel normal again. Mistake 4. Neglecting the heel-to-toe rolling motion. Most adults over 60 have never been told that there is a correct sequence to how the foot contacts and leaves the ground with each step, and that deviating from that sequence has consequences that extend from the ankle to the hip to the cardiovascular system. The correct sequence is this: heel contacts the ground first, with a soft, controlled landing. Weight then rolls forward through the arch. The step concludes with an active push-off from the ball of the foot and the toes. This heel-to-toe rolling motion is the body's built-in shock absorption system, distributing the impact of each step progressively through the ankle, the arch, and the forefoot rather than transmitting it as a single compressive force. When this sequence is disrupted, when the whole foot lands flat, or when toe-first contact occurs, the shock-absorbing mechanism is bypassed entirely. That impact transmits directly and abnormally through the ankle, knee, and hip joints. In adults with already thinning articular cartilage, this is not a theoretical concern. It is accelerated cartilage degradation occurring with every step of every walk. The calf muscles, the gastrocnemius and soleus, are only fully activated during the push-off phase of the heel-to-toe sequence. When that push-off is absent, calf activation is minimal, and reduced calf activation means a compromised calf muscle pump, the mechanism responsible for driving venous blood back up from the lower legs against gravity. The downstream result is venous pooling, swelling, and circulatory symptoms that compound with every mile walked incorrectly. Reduced ankle mobility, caused by Achilles tendon shortening and joint stiffness, both extremely common after 60, is frequently the structural reason this pattern is lost. The range of motion required for a full heel-to-toe roll simply no longer exists without deliberate restoration. The correction: Daily calf stretching and ankle mobility work performed before each walk, not after, to restore the range of motion the heel-to-toe sequence requires. Then, during the walk, apply conscious sequencing. Heel down, roll through the arch, push off from the toes. Begin at a slightly reduced pace until the pattern becomes automatic. Mistake 5. Walking exclusively on flat, familiar surfaces. This is the mistake that feels the most like safety, and is, physiologically, the opposite. The body's balance system is an integrated network. The vestibular apparatus in the inner ear, the proprioceptive sensors in the feet and ankles, and the visual cortex working in coordination to detect postural threat and generate corrective responses in real time. This system does not maintain itself passively. It maintains itself through challenge. Consistent exposure to mild balance demands, minor terrain variation, slight surface unpredictability, keeps the neural circuitry active, responsive, and fast. Consistent avoidance of those demands allows that circuitry to atrophy, predictably, measurably. When an adult walks the same flat pavement loop at the same pace every day, their balance system receives no meaningful stimulus. It adapts to that predictability by reducing the sensitivity and speed of its corrective responses, because those responses are never needed. Then, the moment that adult steps onto a patch of grass, crosses a gravel driveway, or navigates a slightly uneven curb transition, their balance system encounters a demand it has not been trained to meet. This is where the falls that are classified as sudden or unexpected actually come from. They are not random. They are the predictable outcome of a balance system that was never challenged. Many adults migrate unconsciously toward flat, familiar routes as their walking confidence decreases, shortening their route, avoiding slopes, sticking to the smooth pavement they know. It feels like prudent self-protection. It is, in practice, the progressive withdrawal of the only stimulus that keeps the fall prevention system functional. The correction: deliberate progressive introduction of mild terrain variation, 3 to 5 minutes of grass, a gentle incline, a textured path within each walk. Begin with a walking companion or near a stable support if confidence is low. The neurological adaptation to varied terrain occurs within 4 to 6 weeks of consistent exposure. The balance system responds to training at any age, but it requires that the training actually occur. Patricia is 71, retired school librarian, sharp, independent, and by almost any measure, health conscious. For 8 years, she has walked every morning without fail. 20 minutes, same route, same pace, rain or shine. She considers it non-negotiable. It is, in her own words, the thing she does for herself. Her primary investment in staying healthy and staying independent. Over the past 2 years, her knees began to ache. Her orthopedist reviewed the x-rays and said the word she had been quietly dreading: osteoarthritis. She accepted it. She is 71. These things happen. Then came the near falls, 3 of them across 18 months, all on the same flat pavement she has walked hundreds of times. Nothing to trip on, no ice, no obstacle. Just a sudden instability that she caught in time, each time, and did not tell her family about. Her lower back began aching on the days she walked further than usual, so she shortened the route, then reduced the pace, then started skipping days she would never have skipped before. Her world quietly got smaller. A new physician referred her to a physical therapist. That therapist watched Patricia walk for 60 seconds. In those 60 seconds, she identified all 5 mistakes in this video, operating simultaneously on every step of every walk for 8 years. Forward head posture, shuffling gait, anterior trunk lean, flat-footed striking, an unchanging loop on flat, predictable pavement. 6 weeks of targeted gait correction followed. No medication, no surgery, no special equipment. The knee pain reduced significantly. The lower back aching after walks disappeared entirely. The near falls stopped. Patricia had been walking faithfully and incorrectly for 8 years. The correction took 6 weeks. That asymmetry is the entire point of this video. Before we get to the corrections, take 60 seconds with this. Answer each question honestly, based on your most recent walk, or carry these questions with you on your next one as a deliberate observation exercise. This is not a judgment. It is a diagnostic tool. Treat it like one. 1. When you walk, where is your gaze directed? At the ground immediately in front of your feet, or at a point roughly 10 to 15 feet ahead at eye level? 2. Do your feet fully lift off the ground with each step, or do they skim, drag, or shuffle along the surface, particularly when you are tired or walking at a faster pace? 3. Does your torso lean noticeably forward as you walk, especially on inclines, or when you pick up your pace? 4. When your foot contacts the ground, does your heel land first, or does your whole foot or your toe make contact at the same moment? 5. Do you walk the same route, on the same flat surface, at roughly the same pace, nearly every time you go out? Here is what your answers mean. 1 or 2 of these patterns present. Begin applying the corrections in the next section on your very next walk. The earlier you start, the faster the neuromuscular repatterning takes hold. 3 or more present. This correction protocol is a clinical priority for your joint health, balance, and fall risk, not an optional wellness upgrade. At your next available appointment, specifically request a formal gait assessment from a physical therapist. Use that exact language. Write it down before you go. What follows is a therapeutic gait reset, a 3-phase corrective protocol structured the same way formal physical therapy gait retraining is structured, not as a wellness suggestion, as a clinical correction plan with a defined timeline and measurable progression. Work through it in sequence. Do not skip ahead. Phase 1. Pre-walk foundation. Begin immediately. Every walk, non-negotiable. Before your first step, complete these 3 preparation checks. 1. Footwear check. Press your thumb into the midsole of your walking shoe. If it compresses easily, the cushioning has expired. Grip the heel counter, the rigid cup around your heel, and squeeze it. If it collapses with minimal pressure, the structural support is gone. More than 60% of adults over 65 are walking in shoes that have exceeded their functional lifespan, often by a year or more. The shoe may look fine. Its ability to protect your joints and support your gait mechanics is not. 2. Posture set. Stand at your starting point before moving. Stack your alignment deliberately. Ears over shoulders, shoulders over hips, hips over ankles. Take 1 slow diaphragmatic breath, expanding the belly, not the chest, and as you exhale, lift the sternum gently and draw the shoulder blades lightly back and down. Hold that position as you take your first step. 3. Gaze set. Before moving, identify a visual landmark 10 to 15 feet ahead at eye level. Commit to holding your gaze at that level for the first 5 minutes of the walk, not at the ground, not at your phone. 5 minutes is enough to establish the cervical alignment that carries through the rest of the session. Phase 2. Single focus correction method. Weeks 1 through 4. Here is the mistake most people make when they try to fix multiple movement patterns at once. They improve none of them. The brain consolidates new motor patterns through deliberate, isolated repetition, not through divided attention across 5 simultaneous corrections. 1 focus per walk. Rotate through the 5 mistakes across the week. A practical rotation. Monday, gaze position and trunk posture. Wednesday, foot lift and heel-to-toe rolling sequence. Friday, surface variation, 3 to 5 minutes off flat pavement. Each focused walk is a direct deposit into the neuromuscular account that governs how your body moves. The return compounds over time. Phase 3. Integration and progression. Weeks 4 through 8. As individual corrections begin to feel less effortful, as they require conscious attention rather than maximum conscious effort, begin combining 2 focus points per walk. Gaze and foot lift together. Posture and heel-to-toe roll together. The combinations will feel demanding initially. That demand is neurological adaptation occurring in real time. In this phase, add 2 minutes of surface variation to every walk: grass, a gentle incline, a textured or gravel path. Increase this gradually, not abruptly. Adopt the conversational pace test as a permanent self-monitoring standard. If you cannot complete full sentences comfortably while walking, your pace has exceeded your aerobic threshold, and gait mechanics will begin to compensate. Reduce pace. Correct mechanics always take priority over speed. Introduce one longer weekly walk, at reduced pace, to build endurance within the corrected movement pattern. Endurance built on incorrect mechanics is not progress. Endurance built on correct mechanics is investment. One final point on the timeline: the brain requires 4 to 6 weeks of consistent correct repetition to consolidate a new movement pattern at the neurological level. That is not a discouraging timeline. It is a precise, reliable one. Every correctly executed step, every deliberate heel strike, every lifted foot, every maintained gaze is a neuroplastic investment. The correction is not immediate, but provided consistency is maintained, it is certain. The protocol in the previous section corrects what is already present. What follows is the structure that ensures it does not return: a walking health system built on 4 permanent pillars that protect gait mechanics, balance capacity, and joint health for the long term. Pillar 1. 3 daily strengthening exercises. Under 8 minutes combined, non-negotiable. A. Glute bridges. 2 sets of 12 repetitions, performed on the floor or a firm surface. The glutes are the primary propulsive engines of correct walking mechanics. Strengthening them directly counteracts the trunk lean, the shortened stride, and the lower back compensatory loading that define 3 of the 5 mistakes covered in this video. B. Single leg balance holds, beginning at 10 seconds per leg and building progressively toward 30 seconds. This exercise directly trains the proprioceptive and vestibular pathways governing real-time fall correction. It is, in clinical terms, the most targeted fall prevention exercise available without equipment. C. Seated dorsiflexion lifts, sitting upright in a chair, actively lifting the front of each foot repeatedly off the floor against gravity. This strengthens the anterior tibialis, the precise muscle whose weakness produces the shuffling gait that is the most direct mechanical precursor to trips and falls. These 3 exercises address the muscular foundation underlying all 5 corrected mistakes. They require no gym, no equipment, and less time than a commercial break. Pillar 2. Annual footwear review. Once per year, not when the shoes look worn but on a scheduled basis. Conduct a structured assessment of your primary walking shoes. Examine 3 specific indicators: heel counter rigidity, midsole compression response, and tread wear pattern. Sole wear concentrated along the outer heel edge is a direct diagnostic indicator of supination and abnormal gait mechanics. Visible evidence of how your foot is actually contacting the ground, regardless of how it feels. Replace shoes on evidence, not appearance. Pillar 3. Terrain rotation. A permanent weekly commitment to walking at least 2 different surfaces, flat pavement and 1 alternative surface, maintains the proprioceptive and reactive balance systems that exclusively flat surface walking allows to atrophy. Grass, a gentle slope, a gravel path, a park trail. The specific surface is less important than the consistent introduction of mild unpredictability. This is not a challenge. It is maintenance. Pillar 4. Annual gait check. Once annually, request a brief gait observation from a physical therapist. Frame it, to yourself and to your physician, exactly as you would frame an annual eye examination or a dental checkup, routine maintenance of a system you depend on completely. Gait deterioration is largely invisible to the person experiencing it. An informed external observation once per year catches what self-monitoring cannot. Here is the frame I want you to hold for everything in this video. Walking is the most available medicine in existence. It requires no prescription, no insurance approval, no specialist referral. But like all medicine, its effectiveness and its safety depends entirely on correct administration. This video was never about criticizing a habit. It was about honoring one, by giving it the precision it has always deserved. Walking is one of the most powerful tools available to you for preserving joint health, cardiovascular function, balance, and independence. That is not an overstatement. It is among the most well-supported conclusions in all of preventive medicine. But the 5 corrections covered in this video are the difference between walking that protects and walking that quietly erodes. And now you know exactly what each of them looks like. Here is your one instruction for today. On your next walk, choose a single correction from this video and apply it consciously for the entire duration. Just one, not 5. 1. Build from there. If you walk regularly with a spouse, a neighbor, or a friend over 60, share this video with them before your next walk together. These 5 mistakes are universal. Most people making them are doing so in complete unawareness right now, on walks they believe are protecting them. And if balance and fall prevention is something you want to understand more deeply, watch the next video. Because what we covered today is the foundation. What comes next takes it further.